Hello, everyone. My name is Dr. Catherine Sachs, and I'd like to welcome you to Policy Proposals to Address Health Literacy Gaps, Recommendations Across the Healthcare Spectrum. I appreciate your taking the time to tune in. To give you a little more about my background, I have a PhD in public policy from the University of North Carolina at Chapel Hill, and my specialty is social determinants of public health. Currently, I serve as an Associate Director of Health Economics at the Milken Institute's Research Department. The Milken Institute is a nonprofit, nonpartisan think tank in Los Angeles, California, although we have offices in Washington, D.C., New York, Singapore, and elsewhere. Last year, our department released a report on health literacy within the United States, which I co-authored with two of my colleagues in the research department, and from which this talk will pull heavily. You can find the report on our website, milkeninstitute.org, or you can link to it using the QR code shown here. This report provides a broad overview of the health literacy landscape in the United States. In Health Literacy in the United States, Enhancing Assessments and Reducing Disparities, we attempt to bring clarity to the debate on this crucial topic. The review and analysis of the main studies, surveys, and health literacy indicators allows us to identify several gaps when assessing the level of health literacy and the impact of policy initiatives. We offer policy recommendations that would help overcome these challenges. Today's discussion will have four main parts: a broad introduction to the concept of health literacy, followed by a discussion of what we know and what we don't know, and where awareness is lacking. I will then talk about technology's role in health literacy, and finish with perhaps the most important topic of all: the interaction of health literacy and health inequities, and strategies to embed equity within health literacy work. So I will begin with an overview of the health literacy landscape. Although some of this might be well known to many, while others may be largely unfamiliar with these concepts, we will go back to the basics here. It's impossible to talk about health literacy without defining it, and without discussing how that definition has changed since the term was first used in the 1970s, and especially since it has risen in prominence since the 1990s. I would like to draw your attention to an editorial published in The Lancet last November, entitled, "Why is Health Literacy Failing So Many?" It is striking that one of the most prestigious medical journals in the world seems to think that health literacy as a concept has been a failure. What the authors don't seem to understand, however, is that their definition of health literacy as focused on an individual's ability represents an outdated definition. The idea that the concept of health literacy neglects societal and structural forces that shape our choices only demonstrates that the authors are out of step with how the field of health literacy and the concept itself has evolved. Today, no reputable public health or health communications expert would agree that health literacy is so narrowly envisioned. So, what is the definition and how has it evolved? There are as many definitions as there are writers about health literacy, but one of the earliest and most cited is the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. The next definition, perhaps one of the most cited definitions within the US at least, is the definition that was used in the Healthy People 2010 and Healthy People 2020 frameworks. That definition is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. However, as previously mentioned, more recent definitions go beyond the individual to organizational health literacy as well. So while personal health literacy is the degree to which individuals have the ability to find, understand, and use information, organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. You can see that this definition has two parts: the personal and the organizational, that is to say, the broader social or structural definition. What I think is really important to remember is that health literacy is not merely an individual trait. It is context dependent. It varies according to the system in which a person is making healthcare decisions. So that is the introduction to health literacy as a concept. Next, we'll go into what we know, information, and what we don't know, the awareness gaps. So looking at the health literacy data that we have for the population, the National Assessment of Adult Literacy, or the NAU, is really the best and only data we have. It's a nationally representative survey of adult literacy that was last conducted in 2003. It consisted of prose and document literacy, as well as some numeracy, and it had a section that was specific to health literacy, as well as a lot of demographic questions. However, it only surveyed English speakers and Spanish speakers who spoke at least some English. What it found was that only 12% of Americans were proficient in health literacy. That means that 88% of Americans were less than proficient. Let me say that again, 88% of American adults in 2003 had less than proficient health literacy. The other things they found were that health literacy is generally quite closely related to general literacy. People who were more literate tended to have better health literacy skills, and that health literacy skills were highly correlated with sociodemographic factors, things like age, race and ethnicity, and educational attainment. Those who scored the lowest on average were those who spoke only Spanish in the home prior to the onset of schooling. I say Spanish because, again, we have no data about the health literacy of people who did not speak either fluent English or Spanish with at least some English. The other thing to note is that these data are 30 years out of date. Going back to the concept of organizational health literacy from Healthy People 2030, the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. We don't really have widespread data on that. To date, the CAHPS, or the Consumer Assessment of Healthcare Providers and Systems, is the only real systematic data that exists. And it really only provides information about the quality of your communication with a healthcare provider. So it surveys people, asking them questions like, how often does your provider explain things in a way that was easy to understand? There's no officially agreed upon measure for how health literate an organization is. Perhaps the best standard that we have are the 10 attributes of a health literate organization as written by the AHRQ. Just to give you an idea, a health literate healthcare organization has leadership that makes health literacy integral to its mission, structure, and operations, integrates health literacy into planning, evaluation measures, patient safety, and quality improvement, prepares the workforce to be health literate and monitors progress, includes populations served in the design, implementation, and evaluation of health information and services, meets the needs of populations with a range of health literacy skills while avoiding stigmatization, uses health literacy strategies in interpersonal communications, and confirms understanding at all points of contact. You might understand this as the teach-back method. It provides easy access to health information and services and navigation assistance. Designs and distributes print, audiovisual, and social media content that is easy to understand and act on. Addresses health literacy in high-risk situations, including care transitions and communications about medicines. And finally, communicates clearly what health plans cover and what individuals will have to pay for services. This can also be thought of as health insurance literacy, which is a skill that is not entirely unique to the United States, but is extremely important in the United States in ways that it is perhaps less so in other countries. Beyond the population level, we can look at health literacy data at the individual level. That is to say, using screening instruments to see how an individual might perform. So the NAL is the only instrument, the only data we have that is valid beyond an individual level for the most part. Other tests were primarily developed for clinical use rather than population assessment. What that means is that they were developed to be used by a healthcare provider with a patient. They were not meant to be deployed in large-scale surveys, and that is not what they can tell you. That said, some of these clinical measures have been validated for broader use in certain contexts. Research has been done using these instruments as indicators of health literacy ability. The screening questions in these instruments often rely on self-reporting. This is in contrast to the NAL, where somebody is given a task, they perform it, and they're scored on how well they do objectively. Individual screeners are often subjective. How many times do you have trouble understanding something? How well would you say you understand? It's your own subjective assessment. Some example of these instruments are the REALM, or the Rapid Assessment of Adult Literacy in Medicine, the Test of Functional Health Literacy for Adults, or TOEFLA, the abbreviated version of that, the STOFLA, Newest Vital Signs, or the NVS, CHOO-ITEMS, the Brief Health Literacy Screen, or the Single Item Health Literacy Screener. That is to say, one question. There's also the eHealth Literacy Scale, eHeals, and the Health Literacy Questionnaire. Again, these are just the most commonly used ones, but there are a variety of instruments in a variety of languages. If you're interested in reading more about different screeners, I cannot highly recommend enough the Health Literacy Toolshed at healthliteracy.bu.edu. So what are the recommendations from this section? Firstly, policymakers push for improved data. Establish a regular population-wide health literacy survey. We can't improve health literacy if we can't measure it. We can't measure its progress, target its weaknesses. The NAL was conducted by the Department of Education, and it really was an assessment of adult literacy. Health literacy happened to be a section of it. But actually, many countries use the European Health Literacy Survey, the primary goal of which is to evaluate the health literacy level of a population or community, and the evolution of sexual literacy in response to large-scale, specific policy interventions. The EU-HLS population-wide survey relies on a broader definition of health literacy, and it's conducted regularly in nationally representative samples from various countries, including some non-EU nations. Secondly, we need to collect health literacy data on populations that are not English or Spanish speaking. This is increasingly important as the demographics of the US are changing. While currently the largest immigrant group in the United States are Latin American or Hispanic immigrants, by 2055, Asian immigrants, who bring a greater diversity of native languages, will be the largest immigrant group in the United States. Additionally, we need to focus on foreign language speakers who live in the US. The language of immigrant communities is different than that of the population living in the parent country, especially within a healthcare setting. Next, we need to establish measures of organizational health literacy, and we need to use them to evaluate providers. We need to require entities like healthcare providers or payers to use these measures to monitor needs and improvements in organizational health literacy. Things like hospitals, health insurance companies. An agreed upon broadly deployed measure of organizational health literacy can allow us to understand how accessible our system is or how accessible it is not, and how to improve upon it. and we need to make these results public. We should require entities to utilize those measures to monitor their achievement of goals and benchmarks. Clinicians, when it comes to individual health literacy, make sure that you select a health literacy screener that effectively measures what you want to know. And be sure that you know what each screening tool does not evaluate. For example, do you want to evaluate the level of a person's health literacy, or just identify patients who might need a little more help? Understanding a patient's level of health literacy allows practitioners to tailor the information they give and to ensure that they are understood. But if you do want to evaluate a level of a patient's health literacy, be clear about what you are evaluating and why. Make sure that your instrument is context appropriate. Make sure the instrument you use has been validated in the relevant population. So for example, context appropriateness. If you are a provider or a clinician who has a lot of pre-appointment forms, and most of your patients do fill those out in advance, that's maybe somewhere where you could have a test. But if you're in a less formal setting where you see patients maybe on the fly, walk-ins, if you're someone who might be worried about the stigma of providing a health literacy test, a single informal question like the single health literacy item screener might be a better way to go. Next, we'll move on to technology and technology gaps. The first part of this is digital health literacy. That is to say, digital literacy as applied to health information. What's important is to get accurate and relevant health information to people from the sources that they are most likely to consult. That source might not be their physician. It might actually be social media. So what data do we have about digital health literacy, digital literacy in health? Well, the results from the NOW do show where people get their health information from. What we found is that people who use the internet tended to have better health literacy, right? However, this happened before the rise of the internet and social media. This data on the internet comes from 2003. That was before Facebook, before YouTube, before Snapchat, before Instagram, and before the rise of large-scale misinformation and disinformation. So the key distinction here is misinformation is information that is wrong, but not necessarily maliciously. The people who are spreading it believe it to be true. Disinformation, on the other hand, is actively disseminated to undermine, right? There is a compounded risk for low health literacy and low digital literacy. Government agencies and healthcare institutions, the CDC, the National Institutes of Health, use social media platforms for sharing health information to complement the conventional approaches. Although public health interventions traditionally relied on publications, written and alternative format, and low literacy initiatives, what we saw in the public health emergency of COVID-19 triggered is that there was increased use of targeted mass media and social media campaigns. And truly, social media are commonly used sources of information. They're user-friendly alternatives to online health content and medical information from traditional sources. Traditional, in fact, meaning something like Wikipedia. That is the website most frequently consulted through search engines. But the health information on a site, even like Wikipedia, might be too complex. Social media is an attractive alternative. Unfortunately, simplification of information may come at the cost of reliability. So again, going back to the COVID-19 pandemic, a 2020 study found that 27.5% of YouTube's most viewed English language videos about COVID-19 conveyed non-factual or misleading information. The other thing about technology is technology itself. Technology itself comes in the role of software and hardware in healthcare, and technology can help. Electronic health records, for example, enable communication between patients and providers before and after office visits, allowing healthcare providers to check patients' understanding and adherence to recommendations. However, EHRs haven't really been adopted in this way. It's still not as widespread as we'd like to see, and it's not used in the targeted way of checking understanding. Automatic reminders or messages via text, mobile app heighten awareness of the importance of regular checkups, target information based on user health profiles. All of that integration can be helpful. It's just not widespread. E-health programs could also target information based on that diagnosed health literacy level, or based on those who are identified as perhaps being high risk for lower health literacy. Other things that technology has improved, things like automated translation can stand in when live translation is unavailable. Absolutely, it is not preferable. But as we see with the rise of AI, things like ChatGPT, all of that in recent months, it's come a long way. And it has the potential to be extremely helpful, especially as the technology improves. When it comes to hardware, wearables, mobile technology wearables are decreasing the cognitive burden on patients. For example, someone who uses a blood glucose monitor that communicates with an insulin pump. There's no room there for the patient to misunderstand, misread numbers, for user error. It's automated. That cognitive load is reduced. That said, this doesn't help everyone equally. Telehealth as well is the topic on everyone's mind, and it's fantastic where it is applicable. But unfortunately, telehealth is not as widespread, and it's not a substitute for in-person healthcare in a lot of instances. So what are the recommendations here? Health communications are especially fraught when they are digital. That said, they can also be especially effective. A systematic review of health literacy interventions found that the use of technology showed greater promise or more significant results than traditional interventions in a variety of conditions and populations. The goal of health communication, conveying accurate information in an understandable way, can be met more easily using technology sometimes. User-friendly website design, increased use of visuals and plain language, assistive technology, even gamification can all render health information more accessible for people, especially those who might have disabilities or difficulty with English. What we need to do is understand where people are getting their information and meet them there. If people are getting their information from TikTok, then we need to meet people on TikTok where they're at. You cannot redirect people to getting their information from a different source. Digital technology creates opportunities to increase understanding using modern communication methods. As in print media, of course, the 6th grade reading standard should be used. And AHRQ and HHS recommend simplifying all health-related communications for online health-related content. When clear, easy to understand information comes from officials and institutional sources, the need to seek out alternative sources of information is lessened. Providers and healthcare systems should integrate technology effectively, adopt EHRs on a more widespread basis, and collect more information. That doesn't just mean health information. That means knowledge about a patient's background and circumstances, social prescribing, the kind of information that is needed, provides a holistic view of a patient's circumstances. Then we need to integrate health literacy diagnostics or risk assessment into those EHRs or patient portals. EHRs could promote more productive engagement with patients based on those specific needs. The information stored in EHRs can help systematically identify if a patient belongs to a vulnerable population regarding health literacy, and then develop tailored interventions. Using cumulative data, emerging technologies like platform-based cloud services, 5G infrastructure networks, these can be combined with techniques like data mining or AI or machine learning and accelerate that individualization in information sharing. EHRs can also be expanded to the community level and customized for educational purposes. Assistive technology can increase accessibility for those with disabilities or lower English proficiency. These are groups that we know from the NAL have a higher risk of low health literacy and often have worse health outcomes. Instead of serving as a barrier, technology, when used appropriately, can increase accessibility through adaptive solutions. But that won't happen naturally or organically. That has to be brought in the design from the get-go. Finally, technology is only as useful as it is usable. There is unequal access to technology, which limits its ability to dampen the impacts of lower health literacy. Things like broadband deserts, infrastructure gaps, information access deserts. If you are going to prescribe or recommend a technological innovation or remedy, you need to make sure that that is appropriate to an individual's circumstances. Finally, the most important part, equity gaps and disparities. Social determinants of health, and does health literacy qualify? Health literacy is increasingly hailed as a strategy to improve the control individuals have over their health. A central critic of health literacy intervention is its overemphasis on individual level factors, something recognized in the World Health Organization's 2008 report of the Commission of Social Determinants of Health that recommend expanding the scope of health literacy to cover the social determinants of health. That's a quote from a 2020 article by Kendir and Breton. What are social determinants of health? Social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. They can broadly be divided into these 5 categories shown on the right: education and access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. Health disparities that we see are often the result of social determinants of health. Groups facing social or other forms of marginalization have worse health outcomes. That means it's not necessarily biology or genetic factors that lead to certain populations having a worse outcome. There's something in the social factors there that is causing that. That means health literacy as a social determinant of health, by improving it, we can potentially ameliorate these health disparities. Health literacy is a property of communities rather than just individuals. So we know that health literacy correlates with other types of marginalization, again, thinking back to the results of the NAL, but we need to provide moderate incentives for providers and patients to spend time on education and wellness, and to do it in a manner that ensures patients can understand. We need to look critically at how we communicate with patients, what demands we are making of them, what skills they need to meet those demands, and how we are making sure that they can do what we ask them to do. This is the heart of health literacy, and it is a shared responsibility. That quote comes from back in 2009, an article by Villar and Mayer. What it boils down to is health literacy does not mean putting the onus on individuals. Unlike what that Lancet editorial would have you believe, health literacy is not an individual characteristic. Large-scale actions targeting health literacy are growing, but they are still insufficient. So far, some of examples of those are the Plain Writing Act of 2010. In 2000, also, Executive Order 13166 and the issuance of national class standards. The federal government established two major regulations to improve information access. So President Clinton's executive order said that federal agencies must examine the needs of and establish services for persons with limited proficiency in English. There's also an office within the Department of Health and Human Services, the Office of Minority Health, which set up these guidelines to promote culturally and linguistically appropriate services or class. The national class standards are a set of 15 action steps intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations to implement culturally and linguistically appropriate services. Perhaps the biggest large-scale effort to improve health literacy so far is the National Action Plan to improve health literacy. Its goals are to develop and disseminate health and safety information that is accurate, accessible, and actionable. To promote changes in the healthcare delivery system that improve information, communication, informed decision-making, and access to health services. To incorporate accurate and standards-based health and developmentally appropriate health and science information and curricula into childcare and education all the way through the university level. To support and expand local efforts to provide adult education, English language instruction, and culturally and linguistically appropriate health information services in the community. To build partnerships, develop guidance, and change policies. To increase basic research and the development, implementation, and evaluation of practices and interventions to improve health literacy. And finally, to increase the dissemination and use of evidence-based health literacy practices and interventions. So what are the recommendations here? Any health literacy intervention needs to center equity. Interventions should be grounded in community-based participatory research principles. CBPR can engage community members who have the knowledge, experience, and expertise related to such issues. Interventions should be culturally appropriate. Those class standards that I previously mentioned should be applied. Only 10 states require cultural competency training as part of their continuing medical education programs for licensure requirements, although 11 are considering similar requirements. Class and health literacy training should, though, be widespread. No state currently requires specific training in health literacy, although elective units on health literacy are becoming available, as you can see at this conference. Extending class or health literacy training to pharmacists, nurses, physician assistants, and others in the healthcare field can also be extremely important. Physicians are not the only healthcare professionals who can benefit from these trainings and from implementing these principles. Finally, interventions should take place in the community. Non-traditional venues for healthcare interventions can be very effective. Houses of worship, for example, have demonstrated effectiveness. Perhaps one of the more well-known examples of a non-traditional venue is the barbershop and beauty parlor. We saw during COVID-19, in fact, the Biden administration attempted to use barbershops and beauty parlors within the Black or African American community as centers to distribute accurate health information about vaccines. We need to meet people where they're at, not where we want them to be. Additionally, successful interventions have more than one method of dissemination or more than one point of contact. That is to say, Repeated exposure or engagement with health information leads to better retention. Places like public libraries, churches, beauty parlors, they've all been used successfully. And that kind of venue should be considered more frequently. Further, a non-medical environment like that can actually facilitate more active engagement with the information. An opportunity to discuss that information is very helpful to understand. Again, meet people where they're at. Health literacy, it's an individual trait, but it's also context dependent. An individual ability to understand and use appropriately health-related information increases when the healthcare system in which they operate is easier to understand. So instead of just focusing on improving an individual's skills through education, what we need are systemic changes that will increase the accessibility and the usability of the information and the health services. That is why things like the teach back method in clinical interactions can be extremely effective, but so too can programs run out of a local public library. As I mentioned previously, information access deserts. People might not have the ability to access accurate information. Organizations within the community are best served to know what would be a good point for disseminating that information. Again, I want to reiterate this point. Health literacy is context dependent. So even if somebody's underlying literacy level does not change, their skills and abilities do not change, health literacy can be improved when the system in which they are existing is rendered more accessible. By targeting organizational health literacy, we can improve population health literacy even without targeting any individual trait within the underlying population. A few more resources before I finish up. Organizational health literacy planning. There's a lot of templates out there. This one is for organizational health literacy. It's called Making Health Literacy Real: The Beginnings of My Organization's Plan for Action. This is an example on the right of what the template might look like. You can find it at the website listed here, or you can go using the QR code. Any healthcare organization or healthcare adjacent organization should be thinking about implementing an organizational health literacy plan, and this is a really good starting point to do so. Culturally and linguistically appropriate services standards implementation. There is an implementation checklist for those national class standards with the class action worksheet and class testimonials, which can be found at thinkculturalhealth.hhs.gov or using the QR code featured here. It provides a worksheet through which you can evaluate how your organization is doing or how you are doing. Are you tailoring your interventions or efforts to include culturally and linguistic appropriateness, etc.? Finally, plain language best practices. Again, 6th grade reading standard. And the Center for Medicare and Medicaid Services actually has published guidelines for effective writing. They can be found at the website listed here. There's also a lot of resources at plainlanguage.gov, not actually just for healthcare or medicine, but for all fields. This is an example of one of the charts. Instead of saying consequently, say so. Don't tell someone to endeavor to do something. Tell them to try to do something. Simple, plain language is more understandable, less likely to be misunderstood, and just overall more effective. Finally, much of this information is available in the report that I mentioned earlier that we put out last year at the Milken Institute. So let's go back to that Lancet editorial that I mentioned at the beginning. Why is health literacy failing so many? In fact, I would agree with Don Nutbeam, who was actually the author of one of the earliest and most prevalent definitions of health literacy as used by the World Health Organization, in his rebuttal to that Lancet editorial. This article, Improving Health Literacy, How to Succeed, published earlier this year, says that it's not health literacy that's failing people. It is those of us involved in health communication and the systems in which we operate that too often fail people, not health literacy. Thank you so much for your time and attention. If you are interested in getting involved with continuing to promote health literacy, please feel free to reach out on social media at Catherine Sachs 3 on Twitter, ksachs@milkeninstitute.org. And I appreciate your taking the time. And I just wanted to show again some of the sources listed. Thank you.